And frankly, I think if you have that discussion with the patient and they understand why you're picking a particular therapy, maybe they're more likely to be adherent with that therapy. And I think patients just appreciate it. I think there was an era where there was more of a paternalistic approach, but that era has passed and patients want the information so that they feel like they're participating in the decision.
Puerto Rico, la casa de Public Health Latam. Ciencia y salud para todos.
Over the past decades, the treatment of inflammatory bowel disease has evolved dramatically from conventional immunomodulators to biologics and targeted small molecules. Gastroenterology has entered an era of precision medicine. Today we are joined by Dr. Edward Loftus, co-director of the Advanced Inflammatory Bowel Disease Fellowship at Mayo Clinic, to explore how far we've come in IBD management and to address an important and timely question. Is there still a role for thiopurines in modern IBD care? Well, thank you for being with us, Dr. Loftus.
Thanks for having me.
Well, could you walk us through the historical process or evolution of thiopurines and the role they played in the treatment of inflammatory bowel disease?
Sure. There are some studies that date back to the 1960s and 1970s suggesting that azathioprine was effective for ulcerative colitis and Crohn's disease. Frankly, I don't think they were put on the map until there was a famous paper in the New England Journal of Medicine in 1980 by doctors Present and Korelitz from Mount Sinai in New York. And that put 6-MP on the map for Crohn's disease. Even after that paper came out, it was probably another 7 to 10 years before there was widespread adoption of thiopurines for IBD. And so when I was in training, that was considered the advanced therapy using azathioprine or mercaptopurine, especially in Crohn's, because we had such limited options. Basically, back then for Crohn's, you just had sulfasalazine, steroids, and surgery. And so for patients who were steroid dependent, we would use azathioprine and 6-MP. And then they were really the primary therapy through the 90s and even into the 2000s a little bit. But then gradually, infliximab came out in 1998, and that was when the era of the biologics began. So by 2010, we weren't using as much azathioprine.
Well, that means that we've had a transition and evolution. And could you explain maybe some of the major breakthroughs?
Sure. So I think the big breakthroughs were the biologics, specifically the anti-TNFs in the very late 1990s and throughout the 2000s. And it became evident that there's two issues, right? There's a safety issue and an efficacy issue, but it became evident by the time of the SONIC trial, which came out in about 2010, that infliximab was superior to azathioprine for treating Crohn's disease, and the combination of the two was even better. And that sort of heralded the high water mark, if you will, of azathioprine, and then since then, the use of azathioprine monotherapy has basically gradually gone away.
So what were the main limitations to provide for that transition in therapy?
Yeah, the thiopurines are, they're great drugs, but they're tricky. So they're slow in onset. There's a group of patients who just doesn't tolerate them. So they have either nausea, vomiting, or arthralgias. Some people are truly allergic to it. Some people can get pancreatitis. They're tricky drugs. They also require drug monitoring, therapeutic drug monitoring. And there's a couple parts of that. One is that you can check an enzyme level beforehand to kind of predict the dose that they need. So it's called TPMT. And if the patient has a low TPMT level, potentially you can overshoot and cause issues like leukopenia with the normal doses of azathioprine. There's also, you can actually measure the metabolites of azathioprine, the metabolites that predict efficacy, but also the metabolites that predict some of the hepatotoxicity. So they're trickier drugs to use. Having said that, they're very, if you know how to use them, they're pretty good drugs.
Well, we're going to go into maybe how to, they're still viable, and but today there's multiple biologic classes and targeted treatments or therapies. How would you describe the current treatment landscape for Crohn's disease and ulcerative colitis?
Yeah, so we have an embarrassment of riches now. So we have so many drugs, it's great. The anti-TNFs are still important, but we also have anti-integrins, which we use more in UC than in Crohn's. We have the anti-interleukins, and that includes ustekinumab, which blocks 12 and 23, but then we have all the new anti-IL-23 agents. We have the JAK inhibitors, tofacitinib and upadacitinib, and then we have the S1P receptor modulators. So we have all these drugs, and part of the issue is sorting out which ones to use, but at least we have multiple drugs, multiple mechanisms of action, and then there are multiple other drug classes that are in the pipeline being developed, which is good.
Well, that's fantastic. Well, given the fact that there are all these possibilities and all these advances, is it still appropriate to ask whether thiopurines have a role in the modern IBD management, or has the question become which patients rather than whether?
Yeah, so it's probably more the latter. Are there specific patients? I would say that the role of thiopurines mostly now are as combination in patients with anti-TNF therapy, because the Achilles heel of anti-TNF therapy is developing antibodies to the drug, and it's well described now that thiopurines prevent or lower the risk of developing antibodies to infliximab. They boost the drug levels of either infliximab or adalimumab, and so they just make that class of drugs more effective. So most commonly, that's where the thiopurines are used.
Okay, is it still then reasonable? Is it a reasonable option, whether it be as a monotherapy or a combination?
Yeah,
therapy?
it's a reasonable option. The other scenario where it's a reasonable option is if you're in a region or country where there's limited access to biologics, then it becomes really important.
Especially because of the costs, or
exactly, costs, insurance coverage, that sort of thing. And that's one thing where the thiopurines excel. They're a low-cost alternative, and so it's reasonable to consider it if the patient is going to have limited access to biologics.
Besides that, how do other factors like age, sex, maybe malignancy or the stage of malignancy or the disease phenotype influence the decision to use or not to use these?
Yeah, so
treatments?
It's a great question. If you're using thiopurines in combination with anti-TNFs, there's this phenomenon described, it's very rare, of hepatosplenic T-cell lymphoma, and for some reason that's going to occur more often in a male who's under the age of, say, 35 or so. So in young males, you wouldn't want to use a thiopurine necessarily. You might consider in that patient methotrexate if you're going to combine with anti-TNF therapy. So that age is important. On the other end of age spectrum, there's some concern that the risk of regular lymphoma, which is still very rare, might be higher in an older patient. So a patient over the age of 70, you might want to think twice before using a thiopurine. But that age range in the middle, between 35 and 70 for men and basically up to 70 for women, you should be okay to use a thiopurine.
Oh, I was just going to ask about gender, if there was a difference. So you just explained it.
Yeah.
How important is it for the decision-making process, having the input with the patient, discussing and having them participate in the decision on what therapy is adequate?
I think it's really important. A lot of patients really appreciate that discussion. And frankly, I think if you have that discussion with the patient and they understand why you're picking a particular therapy, maybe they're more likely to be adherent with that therapy. And I think patients just appreciate it. I think there was an era where there was more of a paternalistic approach, but that era has passed and patients want the information so that they feel like they're participating in the decision-making
Especially
process.
because there are many alternatives, at least more than they were previously.
Absolutely, yeah.
Do you feel that there is clinical guidelines, standard clinical guidelines? Is there a difference in real life practice and on how these thiopurines are being used across different centers. You already talked about the differences in countries because of access
Right.
to other treatments, but is there like a standard procedure?
You know, I think in general, so I'll use the example of combining the thiopurine with an anti-TNF. In general, you're going to see that more often in a physician or a provider who has seen a lot of IBD patients and feels more comfortable with that scenario. If you're a provider who's only treating IBD occasionally, in other words, it's not what you do 100% of the time, you're probably going to be less likely to use that combination. But the guidelines do suggest that if you're going to use anti-TNFs, they're going to work better in combination with the thiopurine than by themselves because of the antibody problem.
Looking into the future, how do you see the use of this treatment specifically during the next decade? Is it still going to be around?
I think it's still going to be around. I think that still, as long as anti-TNFs are around, and I don't see them going away anytime soon, I think thiopurines are going to be around to support that role.
Thank you very much, Dr. Loftus.
All right, thank you. Thanks for having me.
Thank you for helping us know the clinical perspectives of these treatments and for educating our public too. So thank you very much.
Thanks.
And if you want more information on health issues, please follow us on www.phlatam.es.com.